we then acquire images of the brain. And so what we end up doing is then acquiring control images when there's no label applied to the neck blood vessels. And then we can acquire a tag image where a magnetic label is applied. And if you subtract the control from the tag images, you get the difference in perfusion, and you can calculate cerebral blood flow maps. And these can be used to quantify cerebral blood flow in different patient populations. So in terms of our cohort, this included 113 non-carriers from GenFI and 107 pre-symptomatic mutation carriers. So these were individuals that had C9orf72, granulin, or MAPT mutations. If you look, the only difference between non-carriers and pre-symptomatic carriers was that the pre-symptomatic carriers were younger. And in fact, the younger age would favor us to see less blood flow changes in the mutation carriers. So I'll show you the results and explain why this is relevant. There were no other differences in terms of the groups studied. We used a specialized image processing and QC protocol that was based on Explore ASL in order to quality control our scans and select the ones that were appropriate for inclusion in the study. In terms of our statistical analysis, we used linear mixed effects models to test for cerebral blood flow differences between pre-symptomatic non-carriers and mutation carriers in a voxel-based statistical parametric mapping analysis. We also then used the secondary region of interest analysis to explore between genetic subgroup differences. So our linear equation was that the difference in cerebral blood flow would be the product of mutation status, the years to expected symptom onset, and the interaction between mutation status and years to age of expected symptom onset. Sex and site was included as fixed covariates in the analysis, and family membership was included as a random effect. And the way we calculated years to age of expected symptom onset is we took the age and subtracted the mean age of symptom onset within a family. And we used very stringent voxel-wise, family-wise error correction to identify these regions of interest. So in terms of our statistical analysis, once we got maps based on voxel-based analysis, we then overlap these with the Harvard Oxford Atlas in order to generate regions of interest for subsequent analyses. Regional cerebral blood flow was essentially extracted on an individual basis within these ROIs, and then we applied partial volume error correction to these regions of interest to correct for underlying structural MRI effects, for example, atrophy of the brain. So in terms of our results, we found 6 regions of interest, mostly bilaterally, where we saw reduced blood flow in carriers versus non-carriers. This was in the right and left orbitofrontal and insular cortex, and you can see the region is larger on the right. This was in the anterior cingulate paracingulate region, shown here in red. This was in the left middle temporal gyrus, as well as in the right and left supramarginal gyri as well. And this is just the same areas highlighted with the statistical reference, and you can see that the areas of the cluster size that was largest was in the bilateral anterior cingulate region. When we look at the individual, when we plot the cerebral blood flow in carriers in red and in controls in blue, what we see is that initially the carriers had higher perfusion many years before their expected age of symptom onset, but you can see that there's the slope of reduced blood flow got worse more quickly in these patients as they approached their years to expected age onset. And we saw this relationship in all 6 regions of interest. So to summarize the results in the entire cohort, we did observe an inverse association between cerebral blood flow and years to expected age of symptom onset. which remained significant after we corrected for partial volume effects. However, when we did a genetic subgroup analysis with partial volume correction applied, only the C9orf72 subgroup remained significant. So this indicates that the overall results we got were largely driven by this particular genetic subgroup. On average, we saw the change in cerebral blood flow in pre-symptomatic carriers occurring at about 12.5 years before their expected years to age of symptom onset. We did some secondary analyses, and what this is showing here is when we look at blood flow within these particular regions, and we look at individuals who were beyond their expected age of symptom onset. So these were individuals who were like, you know, after when they were expected to get symptoms of disease. The patients who remained pre-symptomatic had preserved blood flow across all of these regions, compared to those who developed symptoms. These individuals had much lower blood flow. So to discuss this, this study demonstrates the potential utility of non-invasive ASL perfusion MRI as an early imaging biomarker for genetic FTD during the pre-symptomatic phase. The orbital frontal insular regions and the anterior cingulate form part of a distributed network, which was previously shown to be involved in aberrant social emotional processing observed in FTD, specifically the salience network. We had evidence for a laterality effect. And why is this important? Well, first of all, we found that the right orbital frontal insular region was more affected than the left. And Bill Seeley had the hypothesis that von economal neurons might be the first neurons to get hit by FTD pathology that resides there, and specifically in the anterior cingulate. And this might be the most susceptible cell type in early behavioral variant FTD. Well, there's been studies showing that there's a higher number of von economal neurons found on the right in postnatal brains. So this may explain why behavioral variant FTD is nearly 4 times as common as presentations with PPA, primary progressive aphasia. We also showed that pre-symptomatic carriers tended to have higher perfusion than non-carriers several years before their predicted age of symptom onset, and that carriers who went beyond their predicted age of symptom onset had lower cerebral blood flow than their non-carrier counterparts in the same time period. So we hypothesized that there may be compensatory mechanisms involving cerebral perfusion at work early during the pre-symptomatic phase in mutation carriers in order to maintain normal brain function. So this is akin to having increased connectivity on resting state fMRI in, for example, ApoE4 carriers when they're very young. And then this starts to reverse and break down as they get older, which is what we're hypothesizing here with blood flow. We also want to point out that pre-symptomatic carriers who went beyond their expected age of symptom onset had higher regional cerebral blood flow than symptomatic carriers. And this may indicate that preserving cerebral blood flow might delay symptom onset and serve as a therapeutic strategy or target. So I just want to end by saying, you know, studying these genetic subgroups of individuals I think is really important because we can learn about the natural history of genetic FTD. I just want to acknowledge funding from the Canadian Institutes of Health Research, the Western Brain Institute, and from CHR Stage Program and Alzheimer's Society Canada for fellowships for my fellows. I'm going to stop this particular presentation and just shift into a different presentation, which is going to be talking about the second half of what we studied. So I'm just going to log out for a second, if you just bear with me. I'm just going to go and shift into sharing screen again. Sorry about this.
Okay.
All right. Can you see my screen now?
Yes, sir.
Yeah.
Okay. And can you see the display version, or do you see the notes format?
We're seeing the notes format.
Okay, I'll just swap again. Sorry about this. It's
Don't
all
worry.
trouble. Okay, can you see that now, the display version?
Okay,
Yes.
okay.
Okay, good. Thank you. So the second half is I'm going to be talking about white matter hyperintensities in autopsy-confirmed frontotemporal lobar degeneration and Alzheimer's disease. This was a study conducted by one of my former fellows, Dr. Desmarais. So in terms of the objectives of this talk, is we're going to describe the white matter hyperintensity burden and distribution in pathologically proven frontotemporal lobar degeneration compared to Alzheimer's disease on antemortem MRI. We will then investigate the brain white matter hyperintensity behavioral correlates of neuropsychiatric manifestations in these different neuropathological entities, and then finally perform an image-guided detailed neuropathological assessment of regions where white matter hyperintensities were observed in representative cases from each of the neuropathological subtypes with the highest burden of white matter hyperintensity. So this paper was published in 2021 in the journal Alzheimer's Research and Therapy. So in terms of background, Alzheimer's disease is the most prevalent neurodegenerative disorder with advancing age, and neuropsychiatric manifestations are frequent and distressing. Frontotemporal lobar degeneration is also very common. It consists of multiple neurodegenerative pathologies with overlapping clinical features. There are various cognitive, neuropsychiatric, and motor manifestations, and the clinical phenotypes can range from behavioral variant FTD to primary progressive aphasia, the cortical basal syndrome, PSP, and FTD with ALS. As I had showed you earlier, the neuropathology underlying Alzheimer's and FTD. In Alzheimer's disease, it's a mixed amyloid tauopathy. So we see neurofibrillary tangles, and we see these astrocytic plaques. The FTLD can be either a tauopathy or TDP-43 proteinopathy, where we can see cortical basal degeneration as one of the tauopathies. PSP, progressive supranuclear palsy with these tufted astrocytes, as another pathology. And you can see frontotemporal lobar degeneration tau-PIX disease with these PIC-like PIC bodies. The TDP-43 proteinopathies, we see these TDP inclusions, and there's multiple different subtypes. So in terms of background, gray matter atrophy has been associated with clinical manifestations of the disease. Specifically, mesiotemporal atrophy is associated with episodic memory and learning deficits, and orbital frontal atrophy is associated with disinhibition and impulsivity. White matter changes have been well studied in Alzheimer's disease, but less well studied in frontotemporal lobar degeneration. And in Alzheimer's disease, they've been associated with executive dysfunction, impaired mental processing speed, and as well as memory deficits. Apart from a few case series of granulin mutation carriers, white matter hyperintensities have not been systematically studied in pathologically proven FTLD, nor have they been associated with neuropsychiatric symptoms. So the objective of this study is to describe the distribution and burden of white matter hyperintensities in pathologically proven cases of Alzheimer's disease and frontotemporal lobar degeneration, and to investigate neural correlates with neuropsychiatric manifestations. So we acquired our cases from the Sunnybrook dementia study. This is an ongoing longitudinal study of subjects with or without cognitive impairment dementia, started by my mentor, Dr. Sandra Black, many years ago. Subjects undergo extensive assessments, including cognitive testing, MMSE, dementia rating scale, and a full neuropsychological battery. Their behaviors were characterized on the neuropsychiatric inventory. They were screened for FTD gene mutations, Alzheimer's gene mutations, and polymorphisms. And they had 1.5 Tesla imaging, which was acquired using a standard quantitative MRI protocol. So we retrospectively identified autopsy-confirmed cases of Alzheimer's disease, as well as frontotemporal lobar degeneration due to TDP-43 proteinopathy, or due to tauopathy, including PIX disease, PSP, and cortical basal degeneration. We also had a healthy control group for comparison purposes. So in terms of data collection, We had sex, age, and education were obtained from this study. We also controlled for vascular risk factors, which is important because they can contribute to white matter hyperintensity seen on MRI. We looked at disease age at onset, age at the time patients were assessed in the study, and neuropathological findings. As I mentioned, the NPI, we used the total score as well as the 12 subscale item scores to look at associations. And then we had a standardized brain imaging volumetric protocol with quantitative T1 MP range, T2 and proton density cases to look at the white matter hyperintensities. These were 3 millimeter resolution. So in terms of our imaging processing pipeline, we used the SABRE Lesion Explorer pipeline developed here at Sunnybrook. This included segmenting the brain into sulcal CSF, ventricular CSF, gray matter, and white matter. Then with the proton density and T2-weighted images, we can outline in a semi-automatic way the white matter hyperintensities. And when you overlay this with the segmented T1 scan, we can then acquire total white matter hyperintensity volumes as well as regional volumes in different regions of the brain when we parcellate. So we looked at total and regional volumetrics of white matter hyperintensities on T2-weighted imaging, and we looked at differences among neuropathologic groups via ANOVA and ANCOVA, controlling for age and vascular risk factors. We also looked at differences between groups using an independent samples t-test. For the association between white matter hyperintensities and neuropsychiatric manifestations, we use linear regression. So the dependent variable was the items on the neuropsychiatric inventory. The predictor variables was regional white matter hyperintensity volumes, and the covariates included age, sex, educational level, and corresponding regional gray matter volumes. In terms of our neuropathological diagnosis, this was done by Dr. Julia Keith and Dr. Andrew Gao, our neuropathologist here. Autopsies were limited to the brain and spinal cord and were performed by an experienced neuropathologist. The neuropathological diagnosis and staging were made for the primary disease process and any coexisting neurodegenerative phenomena at the time of the autopsy, using a standardized blocking and staining protocol for dementia and applying consensus criteria for Alzheimer's and FTLD. Cases were included in the study and assigned into the following diagnostic groups, and I'll go into the breakdown in the next slide, or next couple of slides. We then used an image-guided case-based neuropathological changes. So using the MRI, we found an area of the brain that demonstrated the higher white matter hyperintensity burden. We then passed these images on to the neuropathologist, and they then associated their pathological slices with this region of the brain and then took a closer look at the underlying pathology of the white matter. They also used standardized immunostains for tau, TDP43, alpha-synuclein, as well as A-beta 42. They also looked at inflammatory markers and axonal degeneration markers such as neurofilament light, GFAP, which is a gliosis marker, CD68 as well, which looks at axonal integrity. So in terms of the cases, we had included 58 cases with neuropathologically confirmed FTLD. 32 of these, 22 had FTLD TDP, 10 had FTLD PIX disease, 11 had FTLD tau, CBD cortical basal degeneration, and 15 had PSP. And we included 15 cases of pure Alzheimer's disease. So we excluded cases who had significant other comorbid pathologies such as alpha-synuclein, etc. We also included 35 healthy controls. So in terms of the differences between groups, the groups were well matched. The only difference is that the healthy controls had normal MMSE scores, whereas all the pathological subgroups performed worse on the MMSE. When we look at the baseline presence of neuropsychiatric symptoms, we found that the FTLD PIX group had the highest burden of neuropsychiatric symptoms, followed by the FTLD TDP43 group. When we look at white matter hyperintensities, these are just a couple of the representative case examples. So this is a T2-weighted MRI. You can see that the TTV43 had a lot of white matter disease in the periventricular white matter, mainly in the frontal regions. The tau pics didn't have that much. The CBD cases didn't have that much. The PSP had an intermediate degree. The Alzheimer's disease had more posterior burden of white matter hyperintensities, and the healthy controls had kind of a mixture as well. When we look at the regions, when we look at where white matter hyperintensities were most prevalent, the highest burden was seen in the FTLD-TDP group shown here. This was then when we compared them to controls. This was then followed by the PSP group and then the Alzheimer's group. And so we saw that the FTLD-TDP group had the worst burden, the highest burden in the periventricular white matter, whereas the PSP group was more in the deep white matter. When we look at the regions of interest, so frontal regions, temporal regions, parietal and occipital regions, you can see that the FTLD group in almost every single case compared to controls had extremely high burdens of white matter hyperintensity. But you can see that the Alzheimer's group also had a high burden when we looked at occipital regions. And you could see that the PSP group also had a fairly high burden as well in parietal regions compared to healthy controls. I won't go into this. When we looked at FTLD-TDP subtypes, the samples were too small to make any reasonable conclusion, so I'll skip over that. When we looked at the association between white matter hyperintensities and neuropsychiatric symptoms across all of the different subgroups, what we found was that white matter hyperintensity in the frontal regions was strongly associated with total neuropsychiatric inventory score. And then when we looked at the depressive subscale, we found parietal and occipital white matter hyperintensities were associated with depressive symptoms. When we looked at apathy, we found frontal regions were heavily associated with apathy, and we found nighttime behaviors were also associated with frontal white matter hyperintensities. Looking at our neuropathology, what was very interesting is we were hoping to see some of the different pathologies showing up in the white matter, so seeing TDP43 and tau in the white matter, but we did not see this. We found that almost all cases that had significant white matter hyperintensity showed myelin pallor, which is shown on these first slides, and showed gliosis when we looked at GFAP stained, and we also saw in G axonal loss as well. So these were the common pathologies. And when we looked across, we took representative cases from each group that had the highest burden of white matter hyperintensities on MRI, you could see this, that the common pathology was essentially axonal loss, gliosis, as well as myelin pallor, and that was kind of the most prevalent pathology, and this didn't differentiate amongst the groups. So the highlights and interpretation of our findings. The burden and regional distribution of white matter hyperintensities differed significantly between the neuropathological groups, with the FTLD-TDP group having the highest mean volumetrics globally, and in frontotemporal regions. The FTLD-tau-PIX group had the lowest mean volumetrics globally and in frontal regions, whereas the AD group had the highest mean volumetrics in occipital regions. When we stratified the AD group into those that had concomitant cerebral amyloid angiopathy versus those who did not, the CAA group had a higher burden in the bilateral parietal regions. And specific regions of white matter hyperintensities which correlated with neuropsychiatric symptoms included total NPI with bilateral frontal volumes, white matter hyperintensity volumes, apathy with bilateral frontal volumes, and depression with occipital volumes predominantly. And we found a common pathology underlying the white matter hyperintensities that was not specific to any specific neuropathological diagnosis. And the most frequent correlate was moderate to severe gliosis, followed by moderate to severe myelin pallor and axonal loss. And we also found very minimal vascular pathology. Venous collagenosis was uncommon. No cases had arterial sclerosis, infarction, or hemosiderin microbleeds. Also, the burden and regional distribution of white matter hyperintensities differed significantly between the neuropathological groups. And in terms of FTLD-TDP, this has been studied before in progranulin mutation cases, which have known and extensive white matter hyperintensities. And progranulin functions in neuroinflammation and vasoprotection. And so we think that the TDP groups had gliosis as a mechanism for their neurodegeneration as a result of the gray matter dying off. And so they got secondary Wallerian degeneration. In terms of Alzheimer's disease, we saw the periventricular small vessel disease and some amyloid beta deposition in arteries, arterioles, and veins, which may be contributing to the white matter hyperintensity. So more of a true vascular cause. So the strengths of this study was that it was a fairly large cohort of autopsy confirmed cases of FTLD. Quantitative measures, we use quantitative measures of white matter hyperintensities. The limitations is that we were underpowered for some subgroup comparisons. And because this was an association analysis, correlational relationships does not prove causational relationships. So we don't know if it's the white matter hyperintensities associated with the NPI or the NPI associated with white matter hyperintensity. We don't know the directionality. So where do we want to go in the future? So white matter hyperintensities, we hypothesize, could be diagnostic biomarkers that differentiate between FTLD tau, TDP43, and AD pathologies. They could be surrogate markers for pharmacological trials. They could be potential protective markers for clinical response to psychotropic medications. If we study them longitudinally, we can better understand the observed associations and then possibly imply causation. And then a larger neuropathological series is needed to investigate to see if there are any differences between neuropathological groups in terms of these quantitative histological changes. So I'll end there just by acknowledging the team and the funding, and I will stop there and I welcome any questions. That ends both of my presentations on these related topics. Thank you very much.
Thank you very much, Dr. Masalis, for your presentation. It was very interesting. We're now going to ask here to the people that are connected to Zoom if they have any questions so that we can start a conversation. And also there are about 15 people connected through YouTube. So we're also gonna wait and see if they have any questions. For now, there is a question right here that says the following. It is asked by Danilo Garcia, and he says, do you think that the utility of ASL perfusion has value as an imaging biomarker in non-genetic FTDs?
Yes, absolutely. I mean, this has been studied already, and we know that ASL perfusion can helps in diagnosing, separating cases of FTD from Alzheimer's disease. So for sure, it's an interesting imaging biomarker. It's a bit difficult and finicky to work with because the different scanners have all different protocols. And so you really have to do a lot of work to be able to meaningfully combine the data across all of the scanners. Thank you for that question. Excellent question.
Thank you. There is another question from Sandra. She's writing it in Spanish, so we're going to translate it. But while I receive them, I don't know if any of the people connected here has another question. Pablo?
Yes, thank you. Okay, I am a professor of the doctoral program. I am researcher in neuroimaging, and thank you for your presentation. It was very, very, very clear. And obviously, I have many questions, but I would like to make a little. Actually, I am the chairman of a project that maybe you know is a Red Dot. We are working in different kind of neuroimaging in FTD. So with the arterial spin labeling, maybe you know that there are different kind of options, pulse, continuous, pseudo-continuous ACL. And I would like to ask, what kind of sequence do you prefer to make research? Because right now we have an enormous heterogeneity in that image. So I have some doubts about that.
Yeah, it's a very good question, and it's not easy to answer. I mean, the optimal is pseudo-continuous ASL, but not all scanners have that capacity. So there's differences between Siemens scanners. There's differences between the Philips scanners and the GE scanners. And even the Siemens, the Philips scanners, there are two different protocols that you can use as well. You know, so it becomes very complicated. And I'm not an imaging scientist. I'm a clinician. So my collaborator Brad McIntosh, who would be better able to answer this, he's an ASL expert. But essentially, I mean, we try to use the kind of optimal sequences per scanner. And the second round of Genfi, we tried to get as many people on a Siemens scanner as possible, just to kind of help. But there's a lot of variability in terms of these scan sequences.
Okay, thank you. And I'm sorry, a little question.
Sure.
Yes, yes, and I'm a fanboy of neuroimage. And so in the second study, you show a study of the white matter hyperintensities. And in that study, you mentioned it, that you use proton density image and the T2. So in your opinion, there are other sequences like FLAIR. And the combination between T2, FLAIR, and T1 is a other option to establish the segmentation of the lesion. So in your opinion, if you compare proton density and T2 versus FLAIR and T2, what do you prefer?
Yeah, so it's a good question. So, you know, our protocol can also can handle FLAIR images. And this, a lot of these images were acquired on a 1.5T scanner using a very old protocol before FLAIR became common use. But there is an advantage to using the combination of the proton density scan and the T2 scans and FLAIR as well. So, you know, the problem with FLAIR is that it doesn't have, so FLAIR has advantages in certain areas because of the signal of the CSF, right? So if you use a T2 and there's a white matter hyperintensity in the periventricular area, you don't know if that's, you know, if that is actually a white matter hyperintensity and damage to the brain or just continuation of the CSF or whatever, right? So that's one problem. But the advantage of using the proton density and the T2-weighted imaging is that it allows you to look at other pathologies and distinguish between other pathologies such as perivascular spaces, right? Because they have different imaging features based on, you know, if something's like a, you know, and also using a T1 as well, right? Because you can see black holes and things like that. So I can't remember the exact advantage of the two, but I can get you the details if you'd like. And one of our papers just kind of addressed this. We just went through some reviews. So it's a very, very good protocol. In fact, the protocol we use with the T2 meets the imaging standards for vascular disease associated with dementia. So the advantage of including the proton density and the T2 scan is that it helps you to distinguish between certain pathologies. Like if you have a white matter hyperintensity, you may or may not know that it's actually like that the actual brain tissue in that white matter hyperintensity is actually gone unless you look at the proton density images because of the iso density and hyperintensities. Anyways, I can share with you more detailed information on this, and my colleague has provided a lot of information on this. Dr. Sandra Black is an expert in this.
Oh, really, I very grateful with that information.
I'll send if you can provide Professor Ray's email, and I can send him the information. So
okay,
sure.
Really, thank you.
I will share it with you.
Pardon?
So there are other two questions in the chat, and then I'll give the word to Dr. Santamaria, that is also raising his hand. So there's a question from Jeremy. Jeremy is also a professor in the business department. He works with a lot of neuroscience projects. And he says, are there any treatment implications, earlier intervention implications?
Yeah, so the whole point of studying pre-symptomatic genetic FTD using imaging biomarkers is that we wanted to be able to identify the optimal period to start a therapy. So if someone has a genetic FTD and is at risk of developing FTD, if we start the drug too early, then we may be exposing someone to unnecessary toxicity of a new drug, for example, and not doing anything to alter or prevent the pathology. If we start the drug when someone is already symptomatic, it's probably too late. So the idea is that can we use a combination of biomarkers, imaging, blood-based biomarkers, to identify the optimal phase to start a drug where someone is destined to convert within a few years before, and halt the process before. So the whole goal of using these imaging biomarkers is for that purpose. Did that answer the question? Yes, optimal targeting for starting treatment, yes.
Thank you.
And this is also related, very related with the other question. This is from Sandra Castelblanco. She's a PhD student. And she says, taking into account that biomarkers and diagnostic images are asked by doctors and medicians when the symptoms are already in an early stage, that you can already see the symptoms, when is the best time to take them before they even begin? This is taking into account that it is ideal to detect the disease in very early stages.
Yeah, it's an excellent question, and I don't have a specific answer. What I can say is that based on our results, we're seeing changes about 12 to 15 years before someone's predicted to get symptoms. In using structural MRI, we're seeing a similar time frame, actually a little bit later, it's often more 5 to 10 years. But we really need to have a large cohort of people to answer this question who have been followed from an early pre-symptomatic stage right through to the development of symptomatic disease. And we just don't have enough of those yet in GenFi. So it's a good question, which I don't have a definitive answer. But ideally, 10 to 20 years before. And that's what we're also seeing in Alzheimer's disease.
Great. Thank you, Dr. Masalis. I'm now giving the word to Dr. Santamaria.
Yes, thank you. Thank you so much, Dr. Masalis, for your wonderful presentation and for accepting this invitation, for sharing your work with us. Just to commend you a little bit about our work, we are right now working with a very large Latin American network, trying to understand better the presentation of Alzheimer's disease, but also frontotemporal dementia in our region, in low and middle income countries, constituted by the Latin American countries. And of course, we have measures of genetics, we have some measures of neuroimaging, classical neuroimaging, MRI, structural MRI by using voxel-based morphometry methods, but also we have some important clinical and cognitive measures. So in part, one of the lines of research that we are developing the last years is try to connect some cognitive process in early stages of Alzheimer's disease, but also frontotemporal dementia, connect the cognitive functioning, for instance, in executive functions or particular social cognition tasks, with some neural correlates by tracking MRI. By considering that and knowing all your experience in all those methods and ASL MRIs and other methods, other cerebral blood flow methods, I was wondering if you think that those cognitive changes in the brain could be tracked also by those other methodologies that you are implementing, and how those methods could relate or could dialogue with the classical structural MRI methods or functional MRI methods. And for us, it will be very, very important to know your opinion about those facts.
Yeah, that's a great question. Thank you for that. There's no doubt that, so it's my opinion that all of these different imaging sequences, ASL, resting state, T2-weighted, T1-weighted, volumetric analysis, are all going to contribute as biomarkers. And I don't think any one of them is going to be the perfect biomarker on their own. I think what you're going to end up having is a combination of these different biomarkers that best predict and correlate with cognitive symptoms, behavioral symptoms. The answer to your question is that I definitely think there's utility. Right now, one of my graduate students, my PhD student, is studying longitudinal ASL perfusion in the Gen V cohort, and one of his projects are going to be to see, if there's an optimal period where it seems to determine someone who's converting into FTD. And also, we're going to be doing a brain behavioral correlation analysis with the longitudinal data. Another one of my fellows is writing up a paper now that's looking at brain behavioral correlations with cerebral perfusion at baseline and seeing if longitudinal changes over time in behaviors are predicted by their baseline perfusion scan, and we're seeing some interesting results. So I think there's a lot of work that needs to be done. Does that answer your question? Thanks.
Yes, thank you so much, Dr. Marcelli. And allow me to say you that for us it's a very, very important to try to maintain the academic contact with you, of course, and trying to discuss further in another opportunity about that Red Lab project, that Latin American project in dementias, because I think that it could be great to have also your inputs.
Sure. Yeah, and we're more than happy to share with you our MRI sequence protocols, what we're doing, and then you can kind of test them out on your scanners, right? We have experience with GE scanner, Philips scanners, and Siemens scanners, all three, and I've run ASL on all three. So we can share with you our sequences on each one of these platforms.
Thank you. Thank you so much. Thank you so much.
Thank you, Doctor. We have two more questions. I'm going to read one that we have in the chat, and then I'm going to give the seat to Elkin, who I think has the last question. So the next one is from Dr. Gabriel Castellanos, and he says, I would like to know if the effect size, sensitivity, specificity of ASL in Alzheimer's or FTD is known. And if so, how could it be improved?
Yeah, it's a very good question. I don't have the numbers off the top of my head, and the effect size and also sensitivity and specificity is going to be dependent on many factors. So the study that was done, if it's a small study versus a larger study, right? So I don't have it, but we do know that when we compare FTD versus AD, the ASL perfusion could distinguish between them. And I can share some papers that I've read. But there haven't been very large studies. There's been small studies in clinical groups. So I can tell you we're seeing that they saw differences in, I think, probably 20 FTD cases or 20 or 30 AD cases. So fairly small sample sizes that can be used to distinguish between AD and FTD using ASL perfusion.
Thank you. Thank you very much. And now, Elkin, you have the word.
Okay. Thank you. So thank you, Professor, again, to being here and give us this amazing presentation. So I have one question about, I think it's related from what Professor Santamaria said. And it's, this presentation recalled me when I read from Dr. Lopera's publication about the present representation of Alzheimer's disease and the increasing FDG PET in their population, that they even saw this increase in metabolisms in their young adults. And they always said that this was because of the hyperexcitability that was caused because of the beta amyloid. I don't know if in these models of disease on FTD that we have primary, or we suppose that is primary, other neuropathologies, what is the main cause of this increase in cerebral vascular flow?
Yeah, and it's a very good question. So this raises the issue associated with neurovascular coupling. So in Alzheimer's disease, the more we study Alzheimer's disease, the more we realize that because patients who get Alzheimer's disease, the majority are older, it's actually a vasculopathy. And it could be a vasculopathy because of concomitant risk factors, increasing risk, and in combination with the underlying Alzheimer's pathology and those preserved, or in younger onset, like such as the dominantly inherited Alzheimer's network, they showed early perfusion changes even in dominantly inherited Alzheimer's disease, and these changes happened before. And in that disease, it may be because of cerebral amyloid angiopathy, so a vascular cause, a vascular etiology. In FTD, I think it's much less likely to be a vasculopathy. And what we're seeing is that when the pathology affects different regions of the brain, you get neuronal dysfunction. And as a result, that region of the brain doesn't function as well, doesn't need as much blood flow, and therefore you see blood flow reducing. So that's the neurovascular coupling hypothesis. And I think the same is seen in Alzheimer's disease, but there's probably a heavy vascular burden. When we looked at, what's very interesting about our white matter hyperintensity study is that when we looked at the correlation between cortical atrophy and white matter hyperintensity volume, we saw that in frontotemporal lobar degeneration, especially TDP, when there was cortical atrophy, there was a strong correlation between the white matter hyperintensity burden. The more atrophy was associated with more white matter hyperintensities, meaning that, that essentially the neurons died back, there was gliosis. Whereas in the Alzheimer's group, we didn't see a strong association between brain atrophy and the white matter changes. And this may suggest that the white matter changes in Alzheimer's disease may be more vascular in origin rather than dependent on the underlying neurodegenerative process.
Okay, thank you, Professor.
Thank you, Dr. Macelis. I think we don't have any more questions for now, but I want to thank you for joining us in this space. This is we do this every month with experts in different topics that are of interest for the neuroscience community of the university. So we're very glad to have you here, and I'm pretty sure that there are a lot of possible collaborations between your work and what we are doing. Excellent. So you're probably going to be hearing from us and from some of us pretty soon. This is also going to be online. So as soon as I have the link of the whole talk, I will send it to you so that you can share it with whomever you might like. And that's it from this side. I don't know if you have anything else. Thank you very much for this interesting talk.
Thank you very much for inviting me. It's been a great pleasure, and I look forward to discussing possible collaborations with everyone. Thank you so much.
Thank you so much.
Thank you so much.
Thank you so much.
Bye-bye.
Bye-bye. Thank you very much.